As we get started here, I'd first like to thank the organizers and so many friends in the room. It's great to be here and share our data and our talk. So the talk I was tasked with was active surveillance as a treatment alternative for small renal masses. And I changed the title a little bit. The way we think about this is really that active surveillance is the default for the management of small renal masses and really should be thinking about a reason to intervene on these patients. And so hopefully over the next several minutes I can explain that to you. Do you guys have my slides in the back? Perfect. Okay. So no relevant financial disclosures here. So this is a quote that Bal Carter used to share with me often when we'd talk about active surveillance, and I bet Dr. Klotz can share a similar experience as the prostate cancer surveillance model came forward over the last few decades. And I would say politely, we're definitely not at 3 yet for active surveillance for kidney tumors and renal masses. So we're going to start by understanding the rationale and some of the biology of small renal masses. I'll show you some bar data and some of the data for outcomes for patients undergoing surveillance for small renal masses, and then talk to you about some of the clinical applications, right? This is a technical meeting, an applications meeting, so how can we apply this to our patients? So we'll start with biology. I'm not going to spend a lot of time on here. Everybody pretty much knows this, but 80 to 90% of masses less than 4 centimeters have low to very low malignant potential, and that's based on large extirpative series. And that says we're doing upwards of anywhere from 5 to 13,000 potentially unnecessary surgeries per year in the US. The Mayo group has also done this really well, and you know that the rates of malignancy and aggressive pathology increase with increasing tumor size and male sex. So you can see the rates of malignancy, but really the important one on the right side are the rates of aggressive malignancy are really low, 10% or less in general for men and women with tumors less than 2 centimeters. And we know there's really low metastatic potential, less than 2% for 4 centimeter tumors, much less than 1% for masses less than 3 centimeters. This is based on institutional data, population-based outcomes, as well as the VHL literature. And very importantly, if you look across oncologic outcomes, no matter what treatment we offer these patients, radical partial ablation or surveillance, the cancer-specific survival is uniformly excellent for T1A tumors. And most importantly, no matter what the age, what the comorbidities, what the treatment is for any patient with a small renal mass, death from competing risks outweighs the death of risk from kidney cancer, and that's a really important take-home. So how has, in my opinion, active surveillance gone from emerging to established? Here's kind of the world's literature on active surveillance as it is right now. Basically what you see is relatively low tumor growth rates, about 1 to 3 millimeters per year. Metastatic progression rates really low. Other cause mortality varies based on patient comorbidities. Cancer-specific mortality is relatively low, and this is reported as relatively low level of evidence, although I'll tell you there's a couple of really large prospective trials, ours being, or registries at least, ours being one of them, that I would argue have slightly higher level of evidence. So in our current guideline statements, NCCN, ASCO, AUA all endorse active surveillance as an option for our patients. I think the AUA probably takes the strongest stance here, saying as it could be an initial management strategy for any patient with a tumor less than 2 centimeters. However, only 10 to 20% of eligible patients in the US undergo active surveillance. Now, it shouldn't be 100%, I would definitely posit that, but it should probably be higher than 20%. And here's some really provocative data. This is SEER Medicare data. This is surgeon-level data of about 13,000 patients with T1A tumors, about 3,000 individual urologists identified as their index urologist. Each urologist saw an average of 11 patients, and the average was about 13% of patients went on to active surveillance among that cohort, but 60% of urologists did not perform any non-surgical management in their small renal mass patients, just showing that we have huge levels of variation on an individual basis and a huge bar to overcome. So why? Why is this? Well, we've got selection and reporting bias and retrospective data. There are really very few established protocols for surveillance. We know that the outcomes for most surveillance patients are based on a composite of benign and malignant, treated and untreated masses. We have no biomarkers, and we know that we have a really high bar in terms of cancer-specific survival, greater than 95%, no matter what we do. So we opened our registry in 2009. We're now 11 years in. We have over 860 patients, almost 500 in the surveillance arm of this program. Now the median follow-up is 3.3 years. We keep adding patients, but we have almost 300 patients who've been followed for 5 years or more. And as you would expect, our surveillance patients, as compared to the concomitantly enrolled intervention patients, are slightly older. They have more comorbidities. They have slightly smaller tumors. And what you see, as you would expect, the overall survival is dramatically different for the surveillance patients than it is for our patients who undergo treatment. But importantly, the cancer-specific survival is incredibly high. And in fact, the only patient we've lost in the surveillance program, actually in retrospect, was a screening failure who had a metastatic node in a rare location that we missed on the initial screen. Importantly, if you look at overall survival by treatment modality, it really reflects their other cause mortality. And when you put this into other models, active surveillance is not a predictor of other cause mortality, just as in age and comorbidities really drive this. And as an interesting aside, we've come up with kind of a retrospective score. And at the bottom component of this, you see PCS, which is a physical component score, a self-reported quality of life. And you actually see the patients who have the lowest reported quality of life in terms of their physical health do the worst. And so if you ask these patients a single question, are you limited in moderate activities like moving a table, pushing a vacuum cleaner, bowling, or playing golf? If they say they're in the worst health there, that patient has about a 50% 5-year mortality from other causes. So how do we follow our patients? Our surveillance protocol right now is imaging every 6 months for the first 2 years, annually thereafter. We do require axial imaging, if not at diagnosis, within the first 6 months of a diagnosis of a small renal mass on ultrasound. We no longer require annual chest imaging because nobody develops pulmonary mets. And we do check their kidney function in a complete metabolic panel annually. We prefer ultrasound as our surveillance modality. Great way to measure tumors. If you see qualitative changes, you can obviously get axial imaging. Although we do recommend to all of our patients that surveillance can be highly individualized. We certainly vary our time intervals based on patient preferences and changes to their tumors, and we do alternate typically axial imaging, either CT or MRI, for our younger, healthier surgical patients who are on surveillance. Here's the spider plot. So you can see the median growth is actually about 1 millimeter per year for our 500 patients, and only about 20% of patients will have a tumor that grows at a growth rate that's worrisome. In fact, 80% grow very slowly or not at all during follow-up. And interestingly, over the last couple of years, we found this phenomenon of disappearing tumors. It's really only about 5% of patients in our program. About half of those will kind of permanently disappear. Some of the ones that appear and reappear are really ultrasound detected or missed, and one of our radiologists has, rather than calling these disappearing tumors, has preferred to sonographically inert, which is a term we kind of like and are moving forward with. But you'll see some of these actually disappear over time. Interestingly, if you look at growth rates, we see that you see the highest growth rates and variation in growth rate within the first year, and then that kind of funnels down. And it's not a selection bias. We've done kind of the sensitivity analyses. These are not patients going to the operating room. And why do we see that? We really think this is a variation in measurement and mathematical artifact. So just kind of hypothetically here, right? You measure a tumor perfectly on a CT scan and say it's a 3-centimeter tumor. You measure that either tangentially or on a different plane, and small changes in measurement over small amounts of time can result in really high growth rates and variation in growth rate, and the longer you follow them, that variation is accounted for. So when we see elevated growth rate in the first year, we tell our patients it doesn't necessarily mean your tumor's growing. We re-image them at a shorter interval, and we'll consider biopsy if they're really worried. When we started the program 11 years ago, our a priori definitions of progression were increases in tumor size based on patient risk, 4 centimeters or 3 centimeters, an elevated growth rate of 0.5 centimeter per year, obviously if somebody developed symptomatic presentation, or we called anybody who electively crossed over a progression. And so our progression-free survival is about 67% at 5 years. And I'll show you kind of some of the data here. A third of the progression events are due to elevated growth rates, but these patients elect not to cross over, meaning they had an elevated growth rate, but we continued to watch them. Some of these were within that first year. Of the crossover events, only about half of those are indicated due to elevated growth. Some of these are patient preference, no longer wanting to do surveillance, changes in health status that allow them to go on, but their tumors stayed the same. These are really similar data from Dr. Uzzo's group at Fox Chase. You see the waterfall plot looks almost identical to ours. About 80% of their tumors don't grow at all. And they really looked at kind of the cumulative incidence of delayed intervention over time. And what you found is over time, more and more patients undergo intervention. And that was really related to growth rate. Importantly, similar to us, they've had one patient die in 5 years. And really, if you look at these data between their program and ours, I would tell you growth rate predicts intervention, but it really doesn't impact our oncologic outcomes at all. And so in our delayed intervention cohort, yes, they grow faster. Half of these are still due to patient preference. We've had no change in our ability to nephron spare. And importantly, we've had no upstaging of no unexpected upstaging or unfavorable pathology. based on high-grade disease or T3. And so we say delayed intervention is safe. We haven't seen any compromise in pathologic stage, oncologic outcomes, or our ability to nephron spare. Interestingly, this is brand new data for us. We've been looking at the rate of interventions based on tumor size, and while growth rates are the same, if a patient starts the program with a tumor that's 3 centimeters or smaller, they've only got about a 15% chance of crossing over in the first 2 to 3 years, whereas it's almost 30% for patients who start off with a tumor greater than 3 centimeters. So this has now started kind of more of our objective consultation for a patient who's got a tumor greater than 3 centimeters. And so finally, just to kind of wrap it up and bring it home, what are we thinking about growth rates and progression now? Here's what we do know. Most tumors grow slowly or not at all. The growth rate in the first year is an unreliable predictor of overall growth rate. Overall growth does not predict malignant biology or metastatic potential, but it does predict intervention. So actually, I told you before about 1 millimeter per year in our cohort. That's not exactly true. And if you follow any individual tumor, they actually grow in spurts or waves, and they may change over time. It's really nonlinear growth. And so we're thinking now about consecutive growth periods, and that, as tumors grow and grow and grow in a persistent fashion, you can actually select out benign or indolent pathologies and may select out more aggressive pathologies. And so we're rethinking progression, understanding that a lot of our patients do progress. Nobody who has progressed has developed metastatic disease. So we know our oncologic outcomes are driven by stage and size. Growth rate poorly predicts malignant potential. So do we need to think like prostate cancer? Is there a grade and stage reclassification? Is persistent growth a measure here? And so finally, this is a focal group, so I'm just going to touch on biopsy. When we first started, less than 5% of our patients underwent biopsy. That's changed dramatically in the last couple of years. It's still only about 10 to 15% of our cohort that gets biopsies. Most of those are in the intervention and crossover cohort. We're really kind of taking to heart using biopsy where it will change intervention here. The reason we don't do that is because of the heterogeneity of tumors. It's really hard to pick out the aggressive tumors. We tell all of our patients, assume you have cancer. And then, interestingly, in Mark Ball's paper here, the only patient who died had a 5% sarcomatoid tumor, really hard to pick up by biopsy. But interestingly, in our biopsy cohort, every patient who's biopsied had improvements in their mental quality of life, basically reduced measures of anxiety and depression. So for select patients, biopsy may improve their quality of life. So we say it's not a requisite for safe surveillance. It may be useful in growing masses. Risk stratification certainly helps when and if a patient could use a biopsy, but it may alleviate disease-related anxiety and depression in select patients. So I'll summarize here. Our current understanding of tumor biology makes surveillance a rational option for many patients with small renal masses. Early statistics certainly demonstrate non-inferiority to primary intervention with excellent metastasis-free and cancer-specific survival. Growth rates certainly predict intervention, but not biology, and we really need to rethink progression. And finally, our current guidelines support the use of surveillance in patients with tumors less than 2 centimeters and those with competing risks of health with masses up to 4 centimeters. I'll take 1 second just to show you one of the big barriers we think, I'm not advancing here, to undertaking and understanding small active surveillance is education. So we've got YouTube videos now at Hopkins. All of our patients, we have a portal where they can follow their own information. This is an individual patient. You can see them mapped out against the entire cohort. And on any given basis, they can come in and see, all right, if I had surgery tomorrow, here's my risk of having a benign tumor, an indolent cancer, an aggressive cancer, and dying of disease. We're working on mapping this out so anybody anywhere in the world can access our data and plug in their tumor data, but we're not there yet. So thanks.